We will now look at a series of pictures representing the clinical spectrum of disease classification. Remember that indeterminate leprosy is not yet on the true leprosy spectrum. Indeterminate leprosy presents with a few hypopigmented macules, shown in this picture. Nerve involvement is not clinically detectable. The incubation period is usually prolonged, with an average 3 to 5 years, though it can be decades. Most cases progress into a later form on the leprosy spectrum, although patients with strong immunity can either clear the infection on their own or persist in this form without progressing. Tuberculoid leprosy, indicated all the way to the left on the diagram we saw earlier, usually presents with large hypopigmented and erythematous macules which are anesthetic. The patch is also dry from loss of sweating and hair. This form of leprosy may have one peripheral nerve affected and usually presents as a mononeuropathy. Infected nerves often thicken and lose function. Progression can occur to more severe forms. Borderline tuberculoid (BT) leprosy is characterized by the presence of skin lesions that are similar to those of tuberculoid leprosy, but are more numerous and may be accompanied by satellite lesions around large lesions. Asymmetrical peripheral nerve involvement occurs. In borderline, also known as mid-borderline leprosy, the skin lesions are numerous but remain asymmetrical. The lesions are usually plaques rather than macules and exhibit satellite lesions. Nerve involvement in borderline leprosy is manifested as thickening or tenderness of local nerves, but the skin lesions retain sensation. Borderline Lepromatous leprosy is characterized by numerous symmetrical small macules, papules, plaques, and nodules, but not the diffuse skin infiltration found in full-blown Lepromatous leprosy. Unlike tuberculoid and Lepromatous leprosy, the borderline forms are unstable and progress to the Lepromatous forms over time unless effective treatment is provided. Reactional states, including both reversal reactions and downgrading reactions, occur in people with borderline forms of leprosy. Lepromatous leprosy is characterized by multiple skin lesions that are smaller than those observed in tuberculoid leprosy. Although the sites of skin lesions are similar to those of tuberculoid leprosy, the multiple lesions of lepromatous leprosy are often symmetrically distributed. Lepromatous macules may have poorly defined borders and exhibit no loss of sensation. Local nerve enlargement is not characteristic. In addition to macules, lepromatous skin lesions may be nodules or plaques, or they may diffusely infiltrate the skin, especially on the face, which may cause loss of eyebrows or, quote, leonine facies, as seen on the picture on the right. Nerve involvement in lepromatous leprosy is characteristically symmetrical and exhibits a stocking glove distribution unrelated to the location of skin lesions. Peripheral nerve involvement may initially manifest as loss of temperature sensation, followed by loss of light touch, pain, and deep pressure sense. In addition, dysesthesia is common. Motor complications, including muscle weakness and atrophy of the muscles of the hands, feet, and face, develop in the absence of effective anti-leprosy chemotherapy. Involvement of the facial nerve may result in corneal exposure, ulceration, and blindness. People with lepromatous leprosy may also have prominent rhinorrhea as a result of nasal mucosal involvement. And they may shed large numbers of M. leprae in their nasal secretions, one of the major sources of bacilli for transmission to other individuals. Like tuberculoid leprosy, lepromatous leprosy is stable and conversion to other forms does not occur. Loss of innervation can cause disfigurement of extremities, shown here on the left. Eyes can be affected too, with blindness as a result, shown here on the right. Testes can also be involved, causing orchitis and sterility. The involvement of the nasopharynx can cause nasal collapse.